From the classroom to the emergency room, OR, and beyond, you're joining Trauma ICU Rounds with your host, Dr. Dennis Kim.
Thanks for joining us on Trauma ICU Rounds. I'm your host, Dr. Dennis Kim, and joining me on Rounds this week is Dr. Scott Brakenridge. Dr. Brakenridge is an associate professor of surgery with tenure in the Division of Acute Care Surgery at the University of Florida in Gainesville, and the center co-investigator at the University of Florida Sepsis and Critical Illness Research Center. He completed his general surgery residency training at UT Southwestern Parkland Memorial Hospital in Dallas, Texas, followed by a trauma surgical critical care fellowship at the University of Washington Harborview Medical Center in Seattle, Washington. And Scott, I want to say a big congrats to you. I saw on social media just within the last couple of weeks, you had made the announcement that you are in fact returning to Harborview. So congrats on that.
Thanks, Dennis. It's great to be on the show and really excited to be here to talk about this stuff. And yeah, it's also exciting to it's always great to have a chance to go back and contribute to a place that built you up. So it's exciting times for sure.
So this term PICS, Scott, when I look at previous research and articles that you and your group at the University of Florida have written on this, PICS stands for persistent inflammation, immunosuppression, and catabolism after shock. And more recently, I've seen PICS used in another context, and I kind of get confused between the two and whether or not they're sort of the same thing with a different name, but the post-intensive care syndrome. Are we talking about the same thing here?
Yeah, it is easy to kind of get tied up in all these acronyms, and especially when they're developed by different people who are studying similar things and kind of end up things getting converged. I think one thing that's important to understand to start out with is that what we're really interested in are patients that survive shock. As intensivists, as surgeons, our job, our expertise is to save patients' lives from septic and hemorrhagic shock. That's what we as acute care surgeons, surgical intensivists do every day. And the bottom line is we've become really good at that. We've really come up well over the past 30 years with novel and aggressive ways to control hemorrhage, to get source control in sepsis, to resuscitate people through sepsis. But what we've come to realize is that mortality, inpatient mortality in these patients, these severely injured patients and patients in septic shock, over the past 20 years, the inpatient mortality has decreased tremendously. So if you look maybe 30 years ago, inpatient mortality in sepsis, septic shock was 40, pushing on 50%. It's currently down to somewhere probably in the teens to 20%. If you look at severely injured trauma patients, hemorrhagic shock, when you take those out with either refractory shock or devastating TBI, mortality in those patients, and these patients were usually dying from multi-system organ failure, was about 20 to 30%, and that's now in the single digits. So, but what we've come to realize is before we run around and start giving ourselves high fives and slapping each other on the back that we've solved the problem, is that we've identified a new, what I'd like to call phenotype of patients that survive shock. And that phenotype is what we call chronic critical illness. And that's really just patients, and any attending, clinician or even down to medical student knows what those patients are when they see them. You see this patient who's been in the ICU for 14 days or more and is just kind of sitting there smoldering. They survived the shock episode, but they're sitting there and they're smoldering with persistent organ dysfunction. They're on CVVH. They're still on the ventilator and they're just not improving. And so those patients, that's the phenotype that we call chronic critical illness. And where PICS comes in, and the confusion with PICS is that, PICS, I'd say, is probably what first described as the post-intensive care unit syndrome. And I think that's the long-term extension of what chronic critical illness is. That's like, how are these patients functionally doing at a year? And, we know that these patients, especially those patients that are CCI patients, those patients that are just smoldering in the ICU, they do poorly, not getting lost in the numbers, but sepsis patients who develop chronic critical illness, half of them are dead at 1 year. And so, again, not getting lost in the acronym. So where does PICS come in? Well, the persistent inflammation and immunosuppression and catabolism syndrome is what we feel like is the pathophysiologic process that drives this problem, this clinical problem that you see.
And so thinking about how this has developed and we've come to recognize PICS, You described the phenotype of the patient, and yeah, I can walk through the ICU. I eyeball my patients. I realize they've been there for a while, and I think right away, oh yeah, this is chronic critical illness, and we should try to change up our management strategy to focus on more things like rehabilitation and good nutrition and preventing complications. What's the characteristic kind of makeup or presentation of these patients from a laboratory or biomarker standpoint? And is this something that we should be looking at commonly or more in the context of basic science research trials?
Sure, that's a great question. And I think that brings up an important point, which I think is to distinguish between two things. And number one is, what's the difference between a phenotype and an endotype? And, the phenotype is exactly what you and I have been talking about. It's walking to the bedside and just seeing that patient clinically not doing well. That's chronic critical illness. It's, this patient is smoldering. They're just not improving. They're stagnated and they're not doing well. Now that there's the underlying pathophysiologic process within that phenotype with what you see, the underlying pathophysiologic process can be a lot more heterogeneous. And so in other words, there can be a lot of different patterns of pathophysiology, immune dysfunction, catabolic dysfunction, organ dysfunction that's happening underneath the things that you don't see, but that are happening biologically. And that's the endotype. And it's really important to distinguish between the two, as that it's important. If the phenotype is the clinical outcome that we see and that we're trying to prevent, but unless we understand what the different endotypes of this single phenotype is, you really can't develop therapies and target useful ways to get these patients better. And so I think that's one thing that's really important is going to be, can we identify ways to individually endotype these patients so we understand which of these mechanisms we're talking about are the mechanisms that are driving these poor outcomes?
And so when you talk about endotypes, is this something that we're identifying on the basis of an array of laboratory tests, or is it based on the patient's underlying genetic profile?
It's all the above. And I think there's different ways to approach it. There are some endotypes that can be determined just by kind of like the routine labs that you're going to see on your CBC and your BMP and your LFTs and things like that. But those are mostly, revolving around organ dysfunction, which we've gotten pretty good. You and I, it's in the ICU, we've gotten pretty good at being able to classify, different levels and stages of organ dysfunction, which is an endotype in and of itself. But then the question of what's the endotype that's driving that underlying organ dysfunction? And that's where it gets a little bit complicated because we really don't have great clinically available biomarkers. I'll just use biomarker in general. And a biomarker can be anything, right? I mean, a biomarker is can be a plasma protein. It can be something like creatinine, like when we were talking about organ dysfunction. It can be a more specific protein, like assessing an inflammatory cytokine, like IL-6. But it also can be something else. It can be an assessment of the patient's immune response by the transcriptional profile, by the expression profile of what the patient's circulating white cells or specific lymphocytes are doing. So there are many ways to endotype a patient. The challenge is how do we translate our findings of what the pathophysiologic process in these patients are. Again, as you mentioned, what we know in these patients that aren't doing well, what we've been able to measure scientifically is that these patients who have chronic critical illness that transitions later into post-intensive care unit syndrome, I think we've had pretty convincing evidence to this time that the pathophysiology driving this in most patients is this underlying endotype of a persistent state of inflammation, a catabolic state where patients can't rebuild muscle mass, and probably most importantly, in my opinion, especially with clinical relevance, is a state of prolonged immunosuppression, where these patients get repeat infections, which add as secondary insults, and it just becomes this vicious cycle that you can't get out of.
This 14-day mark for defining chronic critical illness, is that usually when that switch happens?
Yeah, the 14-day definition actually came from looking at previous data that really came out of some sepsis data for us, but we also have shown that in trauma patients as well. This is that 14-day mark is really where the mortality, the long-term mortality, increases significantly. If you're not out of the ICU by day 14 and you have persistent organ dysfunction, which is still requiring end organ support, especially, your long-term mortality. And that's important, understanding that, as I told you, inpatient mortality is significantly, dropped in the last several years. But until very recently, within the last 10 years, we really didn't know what happened to these patients after we patted ourselves on the back and sent them out to the LTAC or to a skilled nursing facility. And what we found is that those patients that are still in that CCI, that chronic critical illness state, at 14 days with end organ dysfunction. First of all, their discharge dispositions are poor. They're either going to an LTAC or SNF if they survive. And then those patients, the vast majority, well, at least half of those patients, especially within surgical sepsis population, half of those patients are dead at a year, or they have significant functional disabilities, whereas they were, functional, relatively functional or highly functional people before that.
Yeah, and imagine that there would also be some significant downstream effects on loved ones and family members who are going through this with the patients as well. Now, Scott, are there certain risk factors, injury patterns, or specific infections that we should be more or less concerned about when we're admitting patients to the ICU who are sick in the throes of septic or hemorrhagic shock?
Yeah, so the patients, we have a pretty good handle of at least the clinical risk factors of which patients are going to develop CCI and chronic critical illness. And within the trauma population, those patients are patients who are hemorrhagic, clearly in hemorrhagic shock, and or an ISS greater than 25. So high injury burden, hemorrhagic shock. And that makes sense, and really with the underlying pathophysiology, that you have this acute clinical insult that is either severe injury or sepsis, which has this huge systemic inflammatory response initially, and this aberrant host response to injury is one of the key manifestations of determination of who is or isn't gonna recover, especially if you don't resolve that. So in trauma, the patients that are at risk are usually patients that have had hemorrhagic shock, ISS greater than 25. In sepsis, and most people won't be surprised by this, actually age is probably one of the key factors, as well as comorbidity burden, existing kind of low level or incipient organ dysfunction, i.e. somebody who's kind of got stage 2 chronic kidney disease. But then finally, again, the severity of the septic insult and how sick the patient is when they're initially treated, which again raises the point about how important, you and I could debate back and forth with Dr. Martin and Ho and others about what aspects of the Surviving Sepsis campaign are really leading to improved outcomes. But I think one thing that is clear and undeniable is that what that Surviving Sepsis campaign has done is it has brought screening and diagnosis, prompt diagnosis, and initiation of treatment and restoration of end organ perfusion to the forefront. And that's really where the improvement of outcomes is likely to come from. So those are the risk factors for the patients. I think those are the patients that, as you as a clinician in the ICU, need to be keeping an eye out for, and also helping to kind of paint things realistically for the family with regards to, hey, is your 88-year-old loved one who came in with urosepsis and septic shock, you got them through the first 3 or 4 days. You're at 5, 6, 7 days and the patient's not improving and on a trajectory where you think they're going to be in the hospital 14 days in the ICU. I think their long-term trajectory becomes a lot more clear, and that should be helpful to you as a clinician, understanding and trying to help the family understand the implications of what their long-term outcome is going to be and whether or not that long-term outcome is something that would be acceptable to their loved one.
Yeah, that's a great point, Scott. I think anytime patients come in, especially our elderly patients, having these conversations up front is so important to help set those expectations and to get a clearer sense as to where we might end up in terms of trajectory. And the other thing I always ask our learners is functional status. Is this sort of a 65-year-old grandmother who's actively taking care of 5 grandchildren, going and doing all the grocery shopping, cooking, and walking 2 blocks every day, versus someone who's maybe in a little bit more of a morbid kind of condition whereby they're not even doing their own sort of ADLs. And so I think that always helps to kind of set that trajectory right up front as well.
Agree with you 100%.
So one of the things when it comes to trauma, I think when we have a patient who's been severely injured, that ISS greater than 25, blunt polytrauma patient, whenever patients are quote unquote unstable in the ICU, it's always bleeding until proven otherwise. But time and time again, what you see is that, you get your patient their whole blood transfusion, their 1-to-1-to-1. And once you've got the bleeding and coagulopathy under control, they're still in this kind of persistently inflamed shock-like state. And I try to always explain to the learners that this is the systemic inflammatory response syndrome, and they're vasodilated. They've got all kinds of circulating cytokines that are wreaking havoc all over the place. Their SVR is low. They might have some myocardial suppression. And we get so caught up in bleeding, bleeding, bleeding. And of course, for any acute trauma, that's always the way we want to be thinking. But it really is amazing how it just varies from patient to patient, whether it's a prolonged state or something they get over in a day or two. It just seems so variable.
And that's, you're bringing up a great point about how do we take the basic science findings and translational science that we found, or to this point about this underlying pathophysiology, and bring it to the bedside. And the point that you brought up, I think, is extremely important. Is even though we have these clinical risk factors that help us kind of prognosticate how somebody is likely to do, it's almost impossible to say how the individual patient is going to do. And again, that's because of the different endotypes of the underlying disease. And one thing that we've started to show now, and I believe strongly, is that the trajectory of that initial inflammatory response, that initial aberrant host response, your immune system being ticked off from this insult of bleeding and sepsis, and it's at that even as probably more important, and again, we're working on this actively right now, but probably more important than the magnitude of actually the initial inflammatory response and the dysregulation, is how quickly people are able to get back to their homeostasis. So the patient who's starting to look not like that actively bleeding, dying, hemorrhaging patient by the second, third, or fourth day, just physiologically, is a patient that's highly likely to reestablish kind of physiologic and immunologic homeostasis and get back to that baseline. Those are the patients that are going to recover. But it's those patients who still on day, especially, I think the cutoff point is probably going to be about day 4. When you still have those patients who at day by 4 are still acting like that, just severely sursing patient and sucking up fluid, and still has a bit of a vasopressor requirement, and is still on CVVHD, and just physiologically shows that they still have that smoldering fire pit still going, as opposed to getting back to what I say is one analogy I say is it's kind of like a crackling campfire. Your immune system and your kind of physiologic state after septic shock or hemorrhagic shock, you kind of want your immune system to be this cool little crackling campfire. It's cool to sit out the campfire, feel a little bit of the heat, and enjoy the sounds and the crackles. And what happens is when you have sepsis or hemorrhagic shock, somebody throws gasoline on that fire, right? Boom, big explosion. And then the question is, what happens to that afterwards? Do you get back to that crackling campfire, or is it turned into this smoldering mess of coals that you can't cook over, and the embers are flying off and burning you on your skin? And that's really the difference between, I think, the kind of the generalization, or the way that I try to visualize in my simple mind about kind of the underlying pathophysiologic trajectory, that those patients who are either going to rapidly recover the underlying inflammation and catabolism and head on that track to recovery, as opposed to those patients who are just going to sit and smolder. And I think who takes what track at the individual patient level is a lot more difficult to determine. And that's where we're going to have to take the basic science and translate it to the bedside in a precision medicine type fashion to try to identify which of these, can we determine at the patient level which patient is going to take which trajectory, because that's really going to lead to success for targeted therapy.
Yeah, and so much of the latest research when it comes to management of sepsis really does seem to bring into consideration that term of personalized medicine, and really tailoring our approach based on the endotype of the particular patient in front of us. And it does seem that we're starting to recognize that there may be a limited number of ways that patients and sick individuals may respond to a septic insult or to hemorrhagic shock, and seems like a fascinating area of research interest. And I guess right now, as it stands, based on the work that you're doing in your lab, how are things coming along from that standpoint in terms of being able to make that diagnosis and prognosticate early and upfront?
I think we've made a lot of progress in the last 20 years, but it's been 20 years. And we're just starting to see some fruits of that now. Even predecessing my work, my collaborators here at the University of Florida, and this goes all the way back to what some of the at least faculty members will remember as the Trauma Glue Grant. The Inflammation and Host Response to Injury program, which started back in the mid 2000s, was kind of the genesis of all this. And what we learned during the course of that study is that patients who are going to enter that complicated course, that complicated smoldering course, do have a bit of unique transcriptomic. In other words, what are the leukocytes, the lymphocytes, and the leukocytes doing with an individual patient? How are they acting, behaving through their gene activity? And we've been able to identify what that has led to over the past 20 years worth of work now has been we've developed out of the glue grant work and then collaboration with others at the University of Washington, here at the University of Florida, and with the glue grant consortium. We've developed a genomic metric that really boiled it down to 63 genes which we were able to identify, which when measured at within 24 hours of injury are able to give us a pretty good idea prognostically whether or not that those patients are going to still have that complicated outcome, i.e. be that CCI patient at 14 days with an organ dysfunction. We can identify those patients up front with pretty high specificity and sensitivity. Now, the limitation of that is that all sounds great in the lab, but the reality is you want to have an answer quickly, right? You're the trauma surgeon at the bedside. I want to know within the first 24 hours, how that patient is likely to do, because that may help me, raise my threshold for what I need to intervene upon, help guide discussions with the family. But the problem is that, those gene expression type of assays, classically, those are assays that are done over days to weeks. That's not going to help you at the bedside. And so, but what has really changed the paradigm on that recently, and I think this is what is bringing precision medicine, genomic analysis to sepsis and trauma, is really advancements in technology. And these really have taken off in the last 5 to 7 years, where the technology is now at the point where we can actually do these assessments and understand these and read these gene expression signatures instead of days to weeks, on the order of hours to even down to minutes. And so that has been the big game changer. And so I think it'll probably come to sepsis before it comes to trauma, because it actually is starting to be commercialized in the sepsis realm. But obviously, we'd like to be able to finally see this work translate to, at least from a prognostic standpoint, i.e. how a patient's going to do, to the bedside sooner rather than later. I think the cusp is coming. Now, there's another question about, you can have biomarkers and metrics that prognosticate, but another important thing to understand is there's a difference between prognostication and prediction. And so a prognostic biomarker is a biomarker that tells us how somebody is likely to do in an outcome later. A predictive biomarker is different. A predictive biomarker is, can this give me insight into the individual patient's endotype that this biomarker is reading, and allow you to predict whether or not a patient would respond to a given therapy. And I think that's where we still need to do some work. And that's actually the next big step, is because, I think you and I have seen in our careers, and even predecessing our times, the generations of, especially back in what we like to call the sepsis wars of the 80s and 90s, when all the immunomodulators came out, we're going to save the day and cure all our sepsis patients from having the cytokine storm, et cetera. And those all failed miserably. And the problem is that we don't know whether or not the individual agents we're trying to use match up with the endotype that the patients, the pathophysiology endotype that the patients actually have. So I think we're on the cusp of that soon.
And then, Scott, when it comes to patients in hemorrhagic shock, obviously the key principles are, number 1, identify and stop the bleeding. And then number 2, resuscitate, ideally avoiding large volume crystalloids, 1-to-1-to-1 resuscitation, plus or minus whole blood, and or TXA.
And we've seen that, as you and I have seen that, in our careers. I think you and I are probably pretty close to the time frame where, like when I was in fellowship at Harborview at Parkland in the mid 2000s, and then 2010 at Harborview, around the turn of the century, what were trauma ICUs filled with? Trauma ICUs were filled with patients that looked like, the Michelin tire man, with 4 chest tubes in, proned, open abdomens, and, just were total physiologic disasters. And as we have learned how important it is to appropriately and judiciously and rapidly resuscitate trauma patients and get rapid source control, how, entities like post-trauma ARDS / intra-abdominal compartment, abdominal compartment syndrome is an entity that almost is historical at this point. Not completely, obviously, but it's certainly not like it was back in those days, as right. I'm sure, Dennis, that you had seen. So we've seen that is important, and that makes sense. I mean, that was that same underlying pathophysiology is that we were, in a way, almost perpetuating in patients by doing these things. Now we've learned to minimize that, but that is still the same underlying inflammatory pathophysiology that drives today those patients that we get to survive to that point, to having this long-term problem of persistent, of PICS.
Yeah, from swell to get well to pee to be free. It's amazing how things have really evolved. And there's a slide deck that you sent to me, Dr. Brakenridge, and it's labeled The Evolving Epidemiology of Multiple Organ Failure. And this is just a great slide that I want to put up on Twitter and share in the show notes, because it really does kind of show that evolution from the 70s to present day. And you mentioned abdominal compartment syndrome and ARDS and all the lessons we've learned along the way, to the point where, like you said earlier, we've decreased all these early deaths. But then in some cases, we commit these patients to sometimes a fate that may be worse than death if they're stuck in a SNF, unable to interact, return to any reasonable quality of life. And like we mentioned, that has a significant impact on loved ones as well. So we'll post that. So we've got a patient. They've been in the unit for a couple weeks. They're smoldering. They've got a wee touch of the AKI, liver dysfunction, coagulopathy. They're encephalopathic. So what are the things? And we recognize, hey, this patient is chronically critically ill. They've got PICS. What are you doing in your ICUs right now to help decrease that burden of illness and to improve outcomes among these patients?
Yeah, I think there's two major things, and that we can do right now with the information and the tools that we have. Again, we alluded to prompt recognition and treatment of shock is really probably the best thing we can do right now. But after they've kind of gone through that, they've had the insult, and you're kind of resuscitating and taking these patients, what is the best thing we can do right now? And actually, I think that the key thing that we need to understand and try to prevent is secondary insults, because really what we believe that PICS is perpetuated by is this vicious cycle of kind of smoldering organ dysfunction, and you have a dysfunctional immune system. Then what happens to these patients? Well, by day 7, 10, 14, the patients pick up their pneumonia, right? And so that's their secondary insult. And then a few weeks after that, they pick up their UTI, and that becomes another insult. And the patient gets out of the hospital and comes back in 2 to 3 months, and with a pneumonia or a UTI. And so I think that is our biggest challenge right now, is what is perpetuating this is an incompetent immune system that's having these patients have, what we like to call sepsis recidivism. Doesn't matter if it's trauma or sepsis that was the initial insult. The long-term kind of trajectory of this, or the long-term clinical manifestation that we see, is sepsis recidivism.
I love
and
that.
That's actually the case, is that, the patients who, whether it's trauma or sepsis, 60% of the patients that die ultimately after they get out of the hospital die from non-resolving multiple organ failure or recurrent sepsis. Right. And so that's our problem. And so I think, and that's the avenue that I'm interested in very heavily right now, is to targeting and identifying these immune deficits in patients and trying to see if there's ways that we can use, remember, prognostic versus predictive biomarkers to help us determine who might be good candidates for immune potentiating therapy to kind of restore immune homeostasis and competency and prevent this vicious cycle of recurrent infections. So we're not quite there yet, but what you can do in your ICU today is just be really mindful about screening and following patients and identifying patients that are high risk for infection, rapidly treating secondary infections so that these secondary insults don't add on to the underlying problem.
Yeah, I know in our unit, the nurses kind of give me crap sometimes because I'm a big stickler for our checklists and our invasive line monitors. And like you're saying, with the sepsis recidivism, and again, I love that term, we want to avoid things like VAPs and CAUTIs and CLAPSIs and C. diff and SSIs and so on and so forth. And so it's just those simple things. It's a fast hugs BID at the end of your clinical assessment, just to make sure that your patient's getting their nutrition, the head of the bed is up, they've got their VTE prophylaxis. And it's such a critical part of modern ICU care. And I think it's easy to kind of glaze over it and just get on to the next patient. But people don't realize that these are the things that are going to take our patients out and result in, again, a prolonged stay in the ICU, ongoing recurrent infection, multiple organ dysfunction syndrome, and eventually death. Now, what about things like delirium recognition, prevention, management? Does that play into the development of PICS? And what about the importance of things like early mobilization? Because, we hear a lot about the ABCDEF bundle, and I'd imagine if someone's delirious, whether it's a hypo or hyperactive delirium, that in and of itself is associated with worse outcomes. What are you doing in regards to delirium and mobility in your ICU, Scott?
I'm really glad you brought up the concept of delirium and as a really important part of this, because I think that's one thing I kind of tell the residents sometimes is that delirium, is brain failure, right? And so that's the organ failure that we often, as surgeons, we like the glory of organ failures, renal failure, hepatic failure, the stuff that's staring us in the face, right? But really, brain failure is what's really insidious, and that's delirium. And so anything that we can do, and why it's important is because, again, this is something that I think we're being enlightened to now that we're looking outside of the ICU, is that we've shown is that these patients, especially these patients that develop CCI, they have clear cognitive deficits that last months to a year. And so again, it's another organ that is a victim of this underlying pathophysiology. That's an insult from severe septic shock and from severe trauma. So outside of traumatic brain injury. So I think we still have a lot to learn. I think brain failure, quote unquote, is probably the organ failure we know the least about. And but even just recognizing that first of all, detecting it and understanding that it is an organ that fails, and then understanding that it has long-term consequences, and that it's associated with long-term consequences, it needs to be higher on our radar than it is currently. Screening for delirium, whether you use the CAM ICU or something else that as a part of your bundle, as you mentioned before, it's things that we need to be paying attention to every day. And I think it kind of sums together one point I can make is there's not going to be any silver bullet to this, right? So that's why it's so important to all these little pieces together. It's not going to be this drug, this immune modulator that's going to solve this problem. That might be a piece of the puzzle, but it's really going to be reducing all these iatrogenic or secondary insults is really important. Associated in the ICU, it's really important in these patients.
And I think you're absolutely right. The idea that just getting someone started on olanzapine or an antipsychotic is going to somehow just resolve all the environmental, underlying genetic, medical, and other causes that are contributing to delirium is unlikely to happen anytime in the near future. What about mobility and mobilization? This is something that in our ICU we kind of struggle with. It's kind of on our radar. We do well for a little while with things like progressive mobility, and our PTs are so enthusiastic in coming in and helping out. And then, like many good intentions, it kind of falls by the wayside. But how important do you think it is to get our patients up, moving around in terms of helping with some of this sort of catabolism as well as delirium prevention?
Well, I do think it's critically important. And I think, we've all seen these kind of glory pictures on Twitter and other places about the snapshot of the patient in the medical ICU that's up walking on the ventilator. And it's great. I mean, I wish I had every patient of mine on the ICU doing laps of the ICU. Now, as surgeons and traumatologists and trauma surgeons, we have a couple of additional challenges that make that a little bit harder. Broken pelvises, broken femurs, laparotomy incisions that prevent people from being able to tolerate getting up and running laps around the unit. But that doesn't diminish the importance of it. And I think, there's two aspects to that. And I think you're bringing up a good point where I can segue into is the catabolism part of the PICS syndrome is that we know very clearly that patients with that sepsis and hemorrhagic shock and septic shock patients have extremely rapid loss of muscle mass. A good colleague and good friend of mine now, Zubin Puducherry, showed this in sepsis patients, published in JAMA a couple of years ago, is that patients can lose almost 10% of their muscle mass within the first week. And so the question is there's two aspects to that, right? There's going to be a disuse atrophy, but there's also an underlying state of catabolism in these patients where these patients can't re-enter an anabolic state. And so this was kind of alluded to when you were just talking with Dr. Martin and Dr. Ho about early nutrition in these patients. And I love Dr. Martin's analogy, actually, because I use that all the time. The way that I see these patients that are in PICS, we put such a stress on nutrition and making sure we have nutrition on board. Are we meeting nutritional goals? Well, the problem is just like he said, I look at these patients like being a 6-cylinder engine, and you can dump as much fuel into it as an engine with 6 blown cylinders as you want, but it's not going to make any power and go anywhere. So, while mobilization is key, correcting, getting that underlying pathophysiology, that smoldering inflammation, that persistent catabolic state back to your normal homeostasis, back to ability where you can actually use that gasoline is going to be key. And we don't know how to do that yet, but we sure need to try to keep our patients moving to not contribute to the problem.
Yeah, when I think of the young severe TBI patient, it really is remarkable. I mean, they come in, they're robust, they're fit, they've got so much lean muscle mass, and literally, like you said, by a week, you don't even recognize these patients anymore. And that's despite being aggressive with the protein supplementation and the enteral tube feeds, etc. Now, you mentioned the word anabolic, and so is there a role for therapies like anabolic steroids in these patients to help prevent some of that muscle breakdown and maybe retain some strength, or other hormonal therapies like testosterone? Have any studies supported the use of any of these drugs or medications?
The short answer to that, and the cop-out answer, is maybe and no. And we just really don't have the data on it quite yet. I mean,
Right.
we've seen evidence of that in burn populations,
Yeah.
and where those drugs have had significant impact, clear impact on being able to maintain or rebuild muscle mass. But in the setting of patients with smoldering immune dysfunction, I think the answer is we don't know. One thing that I think is important to understand is that this is also a long-term problem. So one thing we've realized is we've now shown recently that this muscle mass loss that occurs, there's a good rule of thumb is that there's a 10% loss of muscle mass in patients with septic or hemorrhagic shock. And we've recently shown that is persistent at least out to 3, if not 6 months after the insult. So this is not a problem that resolves itself. It's this state of catabolism that you can't get out of, right? And so again, as you alluded to, identifying, can we target ways to, allow people to use the fuel that we want to give them? Yes, we need to do it, but I think we still have that engine with 5 out of 6 blown cylinders. We got to get it working before we can actually use that fuel, and we're not there yet.
So outside of active therapies, are there certain medications or drugs we should be avoiding in these patients? For example, neuromuscular blockade or steroids. Is there any data to support not using these sorts of medications? I thought in the past I had also heard something along the lines of aminoglycosides as well as gram-negative sepsis maybe contributing to the development of PICS, but I may be off on that one.
Well, I think the one thing that I humbly disagreed with Dr. Martins and Ho on your sepsis episode was that steroids in sepsis are benign. And I think that in the setting of the trials that exist, which have inpatient or maybe 28-day mortality data, that's a fair summary of the study. But I'm not convinced that that's relative to long-term outcomes, especially when I told you that the major problem with these patients is prolonged immunosuppression and sepsis recidivism, whether or not you're a trauma patient or a surgical sepsis patient. I'm not sure that things like steroids in these patients is benign. And so we don't know, but I think it's risky and to say that they carry no risk. I mean, there's no free lunch in medicine, right? That's another thing we always like to tell our residents. Everything has a risk and a benefit, and I don't think that we completely understand the long-term pathophysiologic risks and how that manifests as long-term clinical outcomes. Because as intensivists, we're just now starting to understand that we need to look beyond ICU discharge as to our patients having good outcomes.
So in terms of what the future holds, it sounds like still quite a bit of work to be done. But where do you think we should be moving towards in terms of recognizing, diagnosing, and treating PICS among our critically ill and injured patients?
I think there'll be 2 things that I think we can see in the short to moderate term future that we might be able to see at the bedside. And I think those 2 things are precision prognostic metrics, like we discussed before, to help us identify early on, so we understand, at least at the patient level, the individual patient level in precision medicine fashion, which patients are looking like that they're highly likely to be on that trajectory. And we need to be really careful and mindful about looking for secondary infections and secondary insults that could really compound the problem. I think that's the first. I think that's coming, I would say, on the scope of, within the next couple years. And then I think the next thing that we'll be able to translate to the bedside, most likely, in my opinion, that the deficit of the PICS deficits I'm talking about, the thing that I think that we can have the greatest impact on patients in the short to moderate term is going to be finding ways to get back to immune competence, treating that immune suppression, identifying patients who have a primary endotype of immune suppression, and understanding that if you can identify that endotype, can we do things that isn't going to perpetuate that, i.e. giving steroids, maybe perhaps inappropriately, versus finding ways, agents, and proceeding with trials to augment those patients and restore immune competence to those patients to stop that vicious cycle of sepsis recidivism. We're starting clinical trials on that now. We're not ready for prime time because I think we're still developing those predictive biomarkers to help us develop these endotypes. But I think that's kind of those are the two areas which I think we'll bring to the bedside in the shortest amount of time.
So, Scott, when we think about this more personalized or individualized medicine practice, do you envision, for example, an increase in the use of cytokine therapies, which we've tried in the past? And then what's the role for immunomodulators in terms of sepsis and septic shock?
Yeah, I think there's actually kind of an interesting side story that has developed in the last 12 years that kind of helped me gain a little bit more understanding is the COVID pandemic. And the immunomodulation within the situation in the context of COVID has been incredibly mixed. And so, and we learned also before, whether or not you try to use something like IL-6 blockade, right? Is IL-6 as kind of the single, probably best cytokine that you want to look at to understand how inflamed a patient is? Sure, that's probably IL-6. But does that mean that giving an IL-6 blockade agent is going to be your miracle cure for that patient? That's the difference between prognostic and predictive biomarkers, right? Is exactly what we're talking about. So if you're asking me about, what direction do I think we need to go as an immune modulatory standpoint, I really think that cytokines blocking the cytokine storm, which is kind of the hot talk. I'm going to give anti-IL-6. I'm going to give high-dose steroids, and I'm going to block the cytokine storm. To me, it's kind of like I think the horse is already out of the barn. And that initial inflammatory response is so complicated. I really don't think that one silver, trying to snip one branch on the tree is going to bring the entire tree down, right? And above and beyond that, I think really, like I said, the agents that we have at our fingertips, I think that are on the cusp of us being able to use are agents that are immune stimulants. So in other words, if we can identify those patients who are in that chronically immunosuppressed state come 7 to 10 days, while they're still in the ICU, hey, somewhere between the first week and the second week, and we are able to measure that, yes, this patient has an primary endotype of immunosuppression. Hey, if we can give these patients an immune stimulant, several of which are in clinical trials now, will that be able to break this vicious cycle of sepsis, recidivism, and trauma and surgical sepsis patients? I think that's where we're headed.
Well, Scott, I want to say I really appreciate you and thank you so much for sharing your knowledge and research experience with us. Any final thoughts as we close out the podcast?
I think that the key message that I'd want to get across to your audience would be is to really just understand that the problem exists and that getting people resuscitated through sepsis, septic shock, and hemorrhagic shock is not the end, it's the beginning. And that discharge from the ICU is not necessarily success. And that understanding that really what we're doing is these lives that we're saving through good trauma and sepsis resuscitation, those mortality benefits aren't really, they're not pure mortality benefits. What we're doing is we're just shifting the burden of the disease to a new phenotype. And so we still have some problems to solve. So I think understanding that problem exists, that just getting out of the ICU is not a victory in and of itself, that we've got to break this cycle of entering a state of chronic critical illness, break the cycle of sepsis recidivism in trauma and sepsis patients, because that ultimately is what leads to long-term outcomes, we believe. And so I think just understanding and grasping that concept, and like I said, what can I bring to the bedside is really just with a high index of suspicion, rapidly treat the state of shock so that you can try to prevent that vicious cycle from beginning.
Once again, Dr. Brakenridge, super excited to finally get you on the show. I want to thank you so much for taking time out of your busy schedule to share your research as well as your knowledge with us. And if you are enjoying the podcast and enjoying rounds, if you feel like we are positively impacting your ability to take care of your patients in the ICU trauma bay wards, please do make sure you share that with the world. You can leave us a 5-star rating at Apple Podcasts as well as a positive comment. Until next time, stay safe, keep reading, take care of yourselves and one another.